as invasive as people may say it is, or how how it may look. This device we use fairly often. It is very, very important, and when it comes to the indications, respiratory rate, accessory muscle use, and your O2 set less than 94%, it is imperative that you treat those patients aggressively if this is deemed necessary. So every single agency has different Cpaps. These are the older ones. You don't really see these too much out in the field now, but I mean the concept is still the same. You're still strapping it to the back of the head, and you still, in most cases, have 2 oxygen sources. Ours at AMR, we only have 1 oxygen source, but more often than not, you'll have the 2. So what's really important with putting these devices on is that it may make the patient feel claustrophobic, and when they're already short of breath, it is very difficult to sometimes get these patients on this, and this is the device they need the most, else they're going to be bagged and obtunded. So as far as the scope goes, with this particular one, you'll probably need 2 people. One person who will be handling the strap, and one person will be holding the mask and coaching the patient. The patient person will probably be best at coaching the patient, making the eye contact, building the rapport, and actually talking to them about how this device will help them and make them feel better. The other person will be taking the straps, putting them in the back of the head, and you want to make sure it's nice and tight with this resting on the bridge of the nose. Put the Cpap on first and establish the pressure while somebody else gets the neb treatment ready, and the neb treatment I'll put on second. So your device, it's very simple. So right here you have your, as far as this one goes, okay, I guess this is centimeters of water this is measuring here. How many liters, how much oxygen is in 5 centimeters of water?
I think it's 10? 8. No, I think it's
15 is what you start at. So 15, 5 centimeters of water, and then from there it's 20 and 25, 7.5, and 10 centimeters of water respectively. Does that kind of make sense? So that's the pressure gauge for this, and you titrate it to the patient's condition, how they're actually responding to this device. So don't always titrate that to the patient's oxygen saturation. You're titrating it to their overall condition and their ability to actually move air. Accessory muscle use is huge, as well as lung sounds and their ability to take that deep breath. So other than that, I mean, it's pretty simple. This one is really not too different. It's still, I think this one still requires the 2 oxygen sources and still has the same band. But like I said, just make sure this is resting on the bridge of the nose and you have a perfect seal around the mouth. And when it comes to giving nitro for your cardiac-related respiratory distress, it should be easy enough just to unclip the bottoms and then do the sprays. But it's more difficult with these older ones. Do you guys have any questions about this as in general before you start doing demonstrations and stuff? Okay. Yeah, it's pretty basic. So as far as placement goes, I'll just go ahead and, who wants to be kind of a dummy? I'm not going to put this actually on your face or anything. But, so
it's not a spread.
So gross, there's like greeny stuff. So pretty much, you're making sure you have your oxygen source. You have plenty of oxygen. This thing just drains O2 tanks, and when you do it, you want to make sure that the patient feels the pressure. You go nice and slow, coaching them the whole way, holding it in place. Your firefighter comes in the back, and when they do the straps on, I guess the dummies are in the other room. It's no big deal though. I find that, I think it was the 3rd one is what I would normally do for, it's really establishing the seal, making sure it's on straight. So, yeah, you guys want to mess with this?
You want me to grab one of the head dummies?
Oh yeah, sure, why not?
Both oxygen sources are at 15 meters.
Right. Okay. So for your neb treatments, as your protocol states, you're doing like
6 between 5
6
to 10. 5
Yeah.
to 10.
What happens is, picture this: you have like 15 liters per minute, 25 liters per minute traveling through here, and you have a low pressure in here and oxygen going up. It makes it very difficult for the neb treatment to go up here when you have this much pressure here. So especially if your patient breathing fast, it can be difficult to actually drop that medicine and actually have that medicine go to the patient. So in some cases you will have to bump that up, especially with these older devices and the Cpap that don't have the built-in one. So just be cognizant of that, and you'll see that because when that mask is actually on, I'm not sure how many neb treatments you guys have actually seen in the field, you'll see it really mist up, and if it's really not misting, that means that medication is still just kind of sitting there not doing anything. You got to turn your leader flow up. But for testing purposes and such, follow what your school says regarding the leader flow. Okay, so that's kind of like your baseline, your foundation for what you need to understand about this device. Your NEB treatments will stay the same as far as liters, and then your O2 source will be 15 to 25 liters per minute of oxygen. So, like I said, this will rest right on the bridge of the nose, right across here. Then, when it comes to putting this in place, your other responder will come right in the back of the head. This should be positioned right in the back there. Nice and tight. And I really can't emphasize enough how important it is to really have a good rapport with your patient, because this is uncomfortable. This is typically pulling hair, and you're pulling their head back and forth, and they're so anxious already. And they really should be, because if they are more lethargic, then you should probably be thinking more along the lines of a patient who needs to be bagged.
Is there a certain order to put the straps on? Like top and bottom, and then...
Back when I used to use these, I would do like, you know, this one and then this one.
Right.
But so long as someone's holding this mask really like firmly to the patient's face, the order really doesn't matter as much. Just kind of splitting hairs at that point.
Got it.
Perfect. Yeah, and then it goes just like that, and then just making sure you keep an eye on this mask and that the seal isn't broken or anything, and that it's actually sized appropriately for the patient's face. A lot of times the Cpap doesn't actually work because, well, for us we have 3 different sizes. We have a small, medium, and a large. People are just, you know, are in a worked up state. They just grab the first Cpap they see, and they're not picking the one that's actually sized for the patient. So that's kind of important. For you guys, maybe in your simulations, just verbalizing that you are cognizant of how big this mask is in relation to the patient you're trying to use it for, because that is important too. You can't really maintain a pressure system if your seal is broken, right? So, yeah, that about wraps it up. Oh, probably need to go over this thing too, actually. So when it comes to putting the treatment in, NEB treatments, I'm not sure if you guys have actually gone over it, just kind of simple stuff, but make sure you actually have your oxygen taken off before you put this in or before you refill it, because if you try to refill this thing when this thing already has a NEB treatment inside of it, it will mist up, make a big mess, looks very embarrassing, don't do it. Then hook up your oxygen source once this thing's all hooked in place, and when it comes to this, this pops right off. Backwards here. And then it just goes right in.
And you said you like to set the Cpap up first, and then you hook your NEB?
Yeah, I'm all about, so it's a simpler version. You might not have all the pieces here to set this up, but
With that, do you always start then? Do you just start at 5 and then you work your way up as needed type of thing?
always, yes. Yeah. Very rarely. I can only think of maybe a handful of situations where you'd even go higher, and more often than not, it's sort of like accidental. Somebody in like the heat of the moment wound us down to the higher level, but it's working for the patient positively, so we maintain it that way. But you always kind of want to least invasive to most invasive within reason. When it comes to respiratory patients, I'm all about being aggressive with this device, but in this particular instance, this is where you can start really trying to fine-tune exactly how much leader flow the patient needs.
So how exactly do you assess, like, okay, I'm at 5 and you want to go to 7.5. How do you assess that 5 is not enough and you want to try 7.5?
The whole picture. So you're looking at the accessory muscle use, the O2 sat, in conjunction with what the patient's blood pressure is. Your patients that benefit best from this are your CHFers. So if the pressure is still high, the accessory muscle use is still there, and you start to see the different changes in the patient's demeanor, their level of anxiety is increasing, or adversely, they start to become more and more lethargic and start to become obtunded. Remember, this is the contraindications for this device. Then you can start increasing it from there. So that's something that, as you go through your internship and see more of, you get more, you know, in tune with determining how much is right for this patient. But just knowing you have the ability to go higher, you have the ability to go more. A lot of my interns, they kind of forget that they put the Cpap on, it's all good and fine, and they're doing their nitros, but they forget that this thing can go up too. And that's important because you really need to get the pressure.
Let's say you start at 5, and then, you know, your patient still, you said the anxiety's coming up, and they look like they're becoming a little more obtunded, but they can still manage their airway.
Mm-hmm.
Would you go ahead and take that off, or just crank it up a little bit more to see if there's a change? to see if the
To-
anxiety
if
goes
they-
down.
Yeah, when it comes to the anxiety, you have to determine if the anxiety is due to this. If it's due to this, you can easily tell because they'll be grabbing at the mask.
Right.
They'll be extremely claustrophobic. If it's the other way around, then you need to look at everything else too. Again, the blood pressure, that accessory muscle use, where is that and where is it present? And that would determine increasing this device, because if the anxiety is tied to their shortness of breath, you need to start really cranking up. They could be on the other end of the spectrum.
Got it.
So this one's also good because this one actually adjusts to the patient's forehead. You can kind of see here, like when you place it on the patient's face. One person can almost do this. What I found, and you may see in your simulations, is if this isn't kind of put away right, this will get tangled up. And this is really cumbersome on your calls too, especially when you have patient's hairs and all that other stuff. So just remember, package this away nicely. It'll do you wonders. And when it comes to placing it on the patient's head, same thing as the other one. It's just a little more... It's just a little easier the way it wraps around. Doesn't really get caught on the hair as much. And then the clasps make it much easier for the nitroglycerin administration should you need it. And remember, you're breaking your seal to do the nitroglycerin administration, but it's just as necessary as everything else. And as long as the seal is maintained for the majority of the patient contact, then you're good. So yeah, see, it wraps right around there. You put the clasps in. From here, you got to work on, especially if you're holding the mask straight, probably doing one down and one above, sort of like. There it is. So you have these straps here. Adjust right here. There we go. Okay, yeah. So it's just these little pull straps here. This is how you would adjust it. So you're just gradually like working your way around and pulling them taut and maintaining that seal. Yeah, it's all the way up here actually. So this one is a lot more comfortable for the patient, especially when the strap is done right, and it's much easier to pull off should you actually need to pull it off. Sometimes this device is removed just because the patient can't handle the claustrophobia and you're actually causing more harm than good because they just get so worked up. So simple there. And as far as the nub goes, let me see if we even have that. Yeah, I don't think this actually fits with this. We can try. We need... I think I might have it in the other room, actually. If you guys want to mess around with these, you can. Be right back.
So if you need to pop that off real quick, like the patient's freaking out, do you just undo the Velcro or do you just do one of those
I'll
little
pull the
buttons?
straps off, and then everything else comes right off.
Okay.
Yeah, if you just unclip those.
Just pop the clip?
Yeah.
Okay.
Exactly. And that's what he's talking about.
Are you gonna pull a case?
Okay.
Are you
Okay, so
Usually not ever.
from that?
show you guys. Okay, so if this is the one that's in your airway bag, you got to make sure you have at least two pieces, or else this entire device is not going to work. So this is really what you'll need. This. So what you notice here is this has a big end, small end. This one here does not work with your device, so make sure you do not have it in your Cpap setup. Just keep this out. It'd be very embarrassing if you're in the middle of a sim and you have this when you really need this. See, what happens is this thing actually doesn't fit with the other end. Oh, it actually does fit. I stand corrected. Awesome.
Oh, thank God.
You guys are okay then. Perfect. Because before, when I used to have this device, we could only use this, and I'm trying to remember why. I think we may have had slightly different sizes of these. That might be it. But no, you guys are golden. So long as you have this piece, then this is the main piece you need. So it seems like there's two here. I don't know if you want to keep an extra somewhere or just know where they are. This thing's pretty jammed in there, so let's just leave it.
Okay.
So perfect. You guys are good. So we'll just keep this here with you guys. And there. It's that simple. And then you just hook that device in. Your neb has the oxygen source in it. Just clip it right in. Very easy.
Corey, for this one, to adjust the flow rate, you have to adjust it on the actual O2 flow, right? To,
For this old one?
yeah, this old one?
Yeah, you have to adjust. You have to adjust the actual oxygen itself, and then when you adjust the oxygen, you'll see the centimeters of water reflected there.
Copy.
So you're just looking at the green bar. I don't even see when the yellow bar would even come into But
20,
honestly,
yeah.
Do you know if most of the ones in the agencies now